Hi everyone. Back with another case study, and this seems to almost be continuing our theme from last week, unknown unconscious in the park, but this will be slightly different, I assure you. We're off to our local park for an unknown unconscious patient, and dispatch tells you sounds more like we have a 20-year-old male who was found supine, gasping, not responsive to bystanders. The bystander called EMS. Quite an intense bystander, dispatch says, so you're on your way. And so this is more or less what you find on arrival. Patient is sort of lying on some leafy pavement there. Looks like he's really struggling to breathe, so much so that he can't really interact with you at all. I've tried my best to make him look cyanotic, so please imagine he's quite cyanosed. So bystander tells you that they initially thought the patient was unconscious or having a seizure, and he was sort of just gasping and staring straight ahead or straight up into the air, and they didn't know what was going on, and they couldn't talk to him, and obviously called you guys. So you may have some thoughts about approaching that scene and what you want to do, and certainly think about those things. And your eagle-eyed partner spots about 20 feet away, this lying on the pavement. So something else you might want to think about with regard to your patient, or maybe it is just a red herring. Who knows? We'll have to do some more investigation and see what we find. So one of the things I just want to stop and have a quick look because we've seen Ventolin. So let's look at the bronchospasm protocol. So this is a really interesting protocol because depending on the severity of your patient, you may choose or have to choose to enter into this protocol in various different places. So probably 99% of the asthmatic patients or the bronchospastic patients you're going to see, you're going to enter into this protocol very high up. So salbutamol with the MDI, um, potentially with some patients, but probably less and less in our COVID days, are you going to be given small volume nebulizers. Probably that's really going to go by the wayside here, I'm guessing. But so MDI puffers, potentially small volume neb. And as I think I probably mentioned ad nauseum probably to you in pharmacology, you tend to see like three types of asthmatics as practicing paramedics, and that's the kind that get better really quickly with your treatment, the kind that don't really change too much at all, and kind of they don't get too much better, they don't get too much worse, and then you get the very, very scary kinds, even some of the young ones who are quite scary this way, who deteriorate quickly and become pericardiac arrest and can go into cardiac arrest. And they're very difficult to manage as cardiac arrest patients, even the young ones. And they are extremely difficult to manage as intubated patients. So I know we learn about RSI this semester, and it does tend to focus us somewhat on RSI as a solution to all things airway and breathing. But really, what we're trying to do with many of these patients is do everything we can to not RSI them. And asthmatics are certainly among those we would choose if we could help it not to RSI. They're difficult to manage. They can have lots of problems on ventilators. And anyway, okay, so I'll stop. I've said enough about that. So then you move down, normal saline bolus. Um, uh, yeah, absolutely a general thing to consider. Magnesium sulfate, which can cause some bronchodilation, excellent thing. Um, but you will have some patients that require very quick emergent intervention. So that's what I mean when I say this is a protocol when you might wind up skipping down a few steps and entering into it quite low down with the epinephrine. So something to think about. Some of your patients may already be past the point where they can breathe well enough that they can absorb the MDI medication where it needs to be, which is far down in the chest. If you have someone who's breathing either very shallow and not moving much air, or very, very rapidly, and they're probably moving, most of the air they're moving is actual dead space air in their upper airways. That those MDIs are going to be, yeah, not so effective. So things to think about when you're interacting with your asthmatic patient is where do they fit on the spectrum of being able to absorb those medications. So here is our young gentleman, 10 o'clock in the morning. You figure he's about 60 kilos. No signs, that should say no signs or history of trauma. GCS is 6, mostly because he does not appear like he can interact with you. So his eyes are opening and closing. He is gasping like a fish out of water. Skin is cyanosed. Very, very weak respiratory efforts. Um, Pulse is weak, but regular at the radial at about 55. So certainly you'll be thinking of some interventions you may be doing for that patient at this point already, and I'm sure already in your mind you're thinking about what you're going to be telling your partner to do. So assuming those things are going forward, basically we'll say you do complete head to toe, probably a very, very rapid and very focused one, depending on what you're thinking is the major problem, which you probably have identified already. So you see some obvious accessory muscle use, but the patient looks like he's very, very tired and not moving a lot of air. The lower chest, when you auscultate, is quiet, and the upper chest are wheezes throughout. But again, on the quieter side. So not what you want to hear. Quiet is not good, obviously, with these patients. So here's some vital signs for you to look at. I won't go all through them. You may have some questions about blood pressure in particular. Something I think it's worth thinking about. Why is the blood pressure as it is? Good, bad, ugly. What are some reasons for that? Um, yeah, so I'll let you look at those. And here is our 12 lead. And again, you can pause and have a look at that. Just see what's going on. Ample history is unknown. We cannot communicate with the patient at this point. He doesn't have anybody around him. We do have that Ventolin inhaler, which we can say is near enough to him. We're strongly considering it's his, but that's what we've got to work with. So now what do we do? You tell me.